Today we're covering mechanical ventilation, a critical life support topic you must know for the NCLEX. The exam will test your ability to connect ventilator settings to patient outcomes and respond to emergencies. Let's start with the core reason for ventilation, which is respiratory failure. The NCLEX will give you a patient with ARDS, a severe COPD exacerbation, or someone failing to wean off anesthesia, and you'll need to recognize these as indications for intubation. The exam focuses heavily on a few key settings. Tidal volume is the amount of air delivered with each breath. Fraction of inspired oxygen, or FiO2, is the percentage of oxygen, which can range from room air at 21% up to 100%. The most complex setting tested is positive end expiratory pressure, or PEEP. PEEP keeps the alveoli open at the end of expiration, improving gas exchange. An exam question might state that a patient's PEEP is increased from 5 to 10. Your immediate thought should be to check for side effects. The increased pressure in the chest can compress the heart and vena cava, leading to decreased cardiac output and dangerous hypotension. Therefore, the priority nursing assessment after a PEEP increase is a blood pressure check. Another key area is ventilator modes. For the NCLEX, you need to know the difference between assist control, or AC, and synchronized intermittent mandatory ventilation, or SIMV. In AC mode, the ventilator delivers a preset tidal volume for every single breath, whether it's initiated by the machine or the patient. A common exam trap involves a patient on AC mode whose respiratory rate increases to 30. Because every breath is a full volume breath, they are at high risk for hyperventilation and respiratory alkalosis. In contrast, with SIMV, the ventilator delivers a set number of breaths, but allows the patient to take their own spontaneous breaths in between. These spontaneous breaths are at the patient's own volume. This is why SIMV is often used for weaning, as it encourages the patient to use their respiratory muscles. Nursing care for an intubated patient is a major focus, specifically preventing ventilator-associated pneumonia, or VAP. You must know the VAP bundle. This includes maintaining the head of the bed at 30 to 45 degrees to prevent aspiration, performing regular oral care with chlorhexidine, implementing daily sedation vacations to assess weaning readiness, and providing prophylaxis for peptic ulcer disease. An exam question will likely present a scenario where a nurse has several tasks to perform, and you must select the action that prevents VAP. Finally, you must be an expert on alarms. The most crucial mnemonic to remember is DOPE. D stands for dislodgement, O for obstruction, P for pneumothorax, and E for equipment failure. The NCLEX will test your ability to differentiate between high-pressure and low-pressure alarms. A high-pressure alarm means there's an obstruction. Think of a patient biting the tube, a kink in the tubing, or mucus plugs in the airway that require suctioning. A low-pressure alarm means there's a leak. This could be a disconnected tube or a cuff leak. In any situation where the patient is in distress and the alarm cause isn't immediately fixable, your first and most important action is to disconnect the patient from the ventilator and manually ventilate them with an Ambu bag while calling for help. This is always the priority safety answer. Weaning is initiated when the underlying cause of respiratory failure is resolved and the patient is hemodynamically stable. They must demonstrate adequate oxygenation with minimal settings and be able to initiate their own breaths. The NCLEX expects you to know these readiness criteria.